Alright, so we are going to deliberate about drugs with cardiotoxic effects. So with the mind map, it summarizes everything. So let's try and brainstorm and bring back every knowledge that we know about it. Alright, so cardiotoxicity may be caused by drugs, and this includes a range of cardiac effects from changes in the blood pressure, arrhythmias, cardiomyopathy. And in literature, mechanisms of drug-induced cardiotoxicity include cellular damage due to the formation of free oxygen radicals, and often agents that cause cardiotoxicity are cytotoxic drugs. So cytotoxic drugs such as anthracyclines are known to have cardiotoxic side effects, and their clinical use is often limited by this cardiotoxicity. So, other cytotoxic drugs with cardiotoxic effects include the um, taxoids, 5-fluorouracil, cisplatin, trastuzumab, which is a monoclonal antibody. So one thing that you have to realize is that for anthracyclines, there has actually been extensive review. So cardiotoxicity has been extensively reviewed with the use of anthracyclines, and they have been reported to cause cardiomyopathy, congestive heart failure, ECG alterations. Both early and late onset cardiotoxic effects are reported. Anthracyclines early onset effect occurs within 1 year after the start of anthracycline therapy, and in children, early onset cardiotoxicity seems to occur less frequently than late onset clinical cardiotoxicity. With the late onset effects, they can occur up to 20 years after completion of anthracycline therapy. And with the risk factors for anthracycline-induced cardiotoxicity include cumulative dose age, concomitant administration with other chemotherapeutic agents, and underlying heart disease, previous radiotherapy. So, of the risk factors, cumulative dose seems to be the most important. And the usual dose of um, doxorubicin is 60 to 75 milligrams per meter square every 3 weeks. So above a cumulative dose of 450 to 550 milligrams per meter square, cardiomyopathy and congestive heart failure can likely occur. They are likely to occur. So risk factors, the maximum dose, cumulative dose needed to obtain minimal cardiotoxicity varies among different anthracyclines, with epirubicin, lower frequency of cardiotoxicity occurs at therapeutic doses compared with doxorubicin. So the mechanism of toxicity, most common hypothesis by which the anthracyclines cause cardiotoxicity, includes the formation of free radicals and superoxides. So this hypothesis is based on in vitro experiments and a few human ones. And with the free radical theory, the reaction starts with one electron reduction of doxorubicin that forms a doxorubicin semiquinone radical. So this semiquinone radical forms a complex with ion, leading to an anthracycline ion 2 free radical complex. So this complex reduces oxygen to yield superoxide, and with the production of superoxide, lipid peroxidation may be initiated. So some studies also indicate that myocardial damage caused by doxorubicin involves apoptosis. Another possible mechanism involves the influence of anthracyclines on the calcium hemostasis. The changes in calcium transport can lead to tissue injury, cell killing, and impaired cardiac contraction. Okay, so involvement of an immunogenic reaction after oxidative stress is also an alternative mechanism. And when you are monitoring and the markers of cardiogenicity, cardiotoxicity. The electrocardiogram is very, very important and can be used to identify the subclinical myocardial dysfunction. So also endomyocardial biopsy directly measures the presence and extent of fibrosis due to anthracycline toxicity, cardiotoxicity. So, however, this biopsy is limited by its invasiveness, need for histologic expertise, and cost. So, troponin T is an indicative of myocardial cell damage and is currently used in diagnosis and prognosis of myocardial ischemia. Yeah, so when you request for cardiac enzymes and you have higher levels of troponin T, you know what you're dealing with. So elevated levels of troponin T has been found in children also treated with some anthracyclines, and studies in adults have given conflicting results regarding troponin T elevations. Alright, so with the prevention and management of anthracycline-induced cardiotoxicity, apart from cumulative dose limitations, a number of methods can prevent anthracycline-induced cardiotoxicity. So antioxidants used as free radical scavengers have been tested in clinical trials, but without significant success. And considering the role of iron and doxorubicin ion complex, ion chelators have been developed to circumvent cardiotoxicity. Alright, so with the prevention, dexamethasone is an ion chelator and has been found to be a promising agent. The dexamethasone can be administered intravenously, either as a slow injection or fast infusion before doxorubicin is initiated. So the dose to be given is usually a tenfold of doxorubicin dose, and lipid lowering agents also seem to be able to lower the cardiotoxic effects of anthracyclines. So another strategy used in the development of liposomal drugs formulation of the anthracyclines. The clinical studies have shown a decreased uptake of doxorubicin in cardiac muscle cells when liposomal formulation is used. And for taxoids, the taxoids, paclitaxel and docetaxel. Paclitaxel and docetaxel, they are important agents in the treatment of a variety of tumors and have been found to have cardiotoxic adverse effects. And during therapy with paclitaxel, various cardiac disturbances like bradyarrhythmias and tachyarrhythmias, AV block, and even cardiac ischemia can occur. Alright, so that's it for paclitaxel. But for hypotension is also reported probably as a result of a hypersensitivity reaction. So another concern with the use of taxoids like the paclitaxel and docetaxel is the development of congestive heart failure. The heart failure usually occurs in patients treated with a combination of doxorubicin and taxoids. And the risk factors for taxoid-induced cardiotoxicity include unstable angina, severe coronary artery disease, congestive heart failure, and atrial fibrillation. However, a study of in patients with cardiac risk factors revealed that paclitaxel could be safe in administered if administered as a single therapy. So paclitaxel is formulated in cremophore. Okay, so let's look at more on the mechanism of toxicity. And it is suggested that the vehicle and not the drug itself is responsible for the cardiac imbalances or disturbances. But then the cardiac rhythm disturbances are not reported with use of other drugs containing chromophore extended release, such as cyclosporin. The possible mechanism is that the chromophore may cause massive histamine release, and in the stimulation of histamine receptors in cardiac tissue in animal studies has resulted in conduction disturbances and arrhythmias. An alternative explanation for paclitaxel cardiotoxicity could be damage via effects of subcellular organelles. And enhanced cardiotoxicity has been found in combined therapy with doxorubicin, and generally at doses of doxorubicin exceeding 380 milligrams per milligram squared or per meter squared, toxicity increases. So when it exceeds that level, toxicity actually increases, and pharmacokinetic interaction appears to be responsible for this effect. Paclitaxel has been found to decrease doxorubicin hepatic elimination, and this results in an increased plasma concentration of doxorubicin. With the prevention and management of toxoid-induced cardiotoxicity, when the taxoids, not toxoids, please. So when the taxoids are combined with anthracyclines, the cumulative dose of the anthracycline should be lowered, and the cumulative doses of doxorubicin up to 340 to 380 milligrams per meter square has been reported to be safe. Alright, so let's move on to 5-fluorouracil. So the use of 5-fluorouracil is associated with myelosuppression, diarrhea, mucositis, and dermatitis. So cardiotoxicity may also occur, and estimates of the incidence vary in 1 to 5%. And this cardiotoxicity with 5-fluorouracil is usually described with continuous infusion and less with bolus ingestion. Alright, so 5-fluorouracil symptoms of with regards to cardiotoxicity includes the cardiac arrhythmias, silent myocardial ischemia, angina pectoris, and then congestive heart failure. And the risk factors include pre-existing coronary artery disease and concurrent radiotherapy. The pathophysiological mechanism of 5-fluorouracil related to cardiotoxicity is still unclear, and some of the hypotheses postulated include vasospasms leading to ischemia, direct toxicity on the myocardium, and activation of coagulation system, and others are coronary artery thrombosis, immunoallergic phenomena, and cardiotoxic impurities in the 5-fluorouracil formulation. Alright, so let's go on to cyclophosphamide and ifosfamide. Cyclophosphamide and ifosfamide, they're actually like alkylating agents that need to be metabolized in vivo to form the active cytotoxic metabolite. So high doses of cyclophosphamide used in organ transplant regimen is often associated with acute cardiotoxicity. And the incidence is estimated to range from 2% to 10%. There's a mechanism is actually not fully understood, but an increase in free oxygen radicals seem to play a role in this cardiotoxicity. Okay, for cisplatin is a platinum substance used in the treatment of many tumors, for example in testicular cancer, and a number of cases of acute myocardial infarction after cisplatin therapy are reported. Several factors suggested to be involved include vascular damage, alterations in platelets aggregation and hypomagnesemia, activation of an arachidonic pathway in platelets by splitting also seems to be involved. Okay, so this something about drugs with um, cardiotoxic effects.